So let's talk about anaphylaxis. Now, the first thing we need to note about anaphylaxis is that it is not an autoimmune condition. Instead, it's what we call a hypersensitivity disorder in the fact that some type of allergen elicits this very exaggerated immune response. And you might be thinking, well, Jordan, what are some examples of that? And my answer to that question is it depends. And the reason it depends is because it's entirely subjective. It could be anything from a vaccine to a toxin to an insect bite to a pollen. It doesn't matter. And the reason it doesn't matter is because very simply, you need to learn what's going on. So I'm going to see if I can teach you exactly that. So what I've got here, firstly, we'll start off with that of an antigen, right? And again, it can be anything. It doesn't really matter. So let's just draw out a very typical example of an antigen. So here are some of my antigens. Great. Now, this antigen has introduced itself into the body, right? And eventually what's going to occur is it's going to come across some B cells, right? And the reason it wants to do that, and I'll tell you in just a moment, is because of the immune system. Now, think about an antigen. An antigen is a foreign invader, and like any foreign invader, the body wants to get rid of it, and it's up to the immune system to do so, right? Now, specifically on the adaptive side of the immune system, what you're going to find is that not only do we start destroying and engulfing these antigens, but also we start to form memory. And this memory is incredibly important, and we use the same principle when administering things like vaccines, right? So what happens is this antigen, it comes along and it stimulates the B cells, which are a part of the adaptive immune system, and simply all they do is they start secreting antibodies. Now, specifically, these antibodies are going to be what we call IgE antibodies. So I'm going to write that out, IgE antibodies. Okay, so they're specific to this antigen and this type of immune response, right? So great. So we've got some IgE antibodies floating around. So what do they do? Well, simply they do really two things. The first thing they do is they come around, and eventually they get to the antigen and they form this what we call antigen-antibody interaction, and simply all it does is it neutralizes the antigen, right? So it comes along, it binds, and it neutralizes the antigen. That's a good thing. But remember what I said before, it also is responsible for making memory, okay? Now, you might be thinking, well, okay, we've used a few of those IgE antibodies to neutralize some of those antigens there, but what that means is that we've still got a few left over, right? They're kind of free floating. They're not really doing too much. So these IgE antibodies, they also come across, right, and start binding to other cell types, right? So I'm just going to draw out some other cell types here. So this is one cell type, and let's say this here, this can be my other cell type. All right, let's say they look something like this, right? Now my purple, they can be my mast cells, and the green can be my basophils, right? And remember, these IgE antibodies, they come along and they simply bind to the surface of these cells, right? And now they're anchored there and they're attached there, which means that upon subsequent exposure to this antigen, and I'm not talking, seconds to hours to days, I could even talk months to years, right? So let's say a year after you've been exposed to this antigen, what you're going to find is that this antigen, when it comes along for the second time, it can directly bind to these IgE antibodies that are already sitting on top of the mast cells and the basophils. And remember that those basophils and those mast cells, they're the inflammatory mediators, right? So what happens is that when this antigen binds to those antibodies on the basophils and the mast cells for the second time now, not the first time, but rather the subsequent exposure for the second time, right? It stimulates those cells to do something, okay? And what is that something? Well, what it does is it produces one of two things. The first thing is that it produces cytokines, and the second thing is histamine, right? Now, I'm not going to explain cytokines today, but I will go through histamine, and histamine should ring a bell for you. Okay, so let me take some of this stuff off the board and reorganize. Okay, done. So what we're going to find, remember, is that upon these antigens binding to the IgE antibodies that are embedded on the basophils and the mast cells, it's going to stimulate those two types of cells to release things, right? Inflammatory mediators, right? And what are those inflammatory mediators? Well, they're going to be things like cytokines that allow for intercellular communication, but also things like histamine, which does stuff. And I'm thinking, what stuff does it do exactly? Well, I will tell you. Okay, so firstly, let's just draw out some histamine. So these are some histamine molecules, and they're kind of coming on out of the mast cell, being secreted after the antigen has bound. Okay, so histamine is being released. That is my take-home point here. So histamine is released, right? Great. Now, this histamine, normally, it comes on down, right? It comes on down and it starts binding to blood vessels. So I'm going to draw out a blood vessel here. All right, so this is one of my blood vessels. And what you're going to find is that on top of this blood vessel, we have little receptors, right? Now these receptors, in this case specifically, are what we call H1 receptors. So let's just write that out, H1 receptors, right? And that H in H1 simply stands for histamine. So you might be thinking, well, good chance histamine will bind to those receptors, and you'd be absolutely right. Okay, so following diffusion, histamine comes on down, right, and eventually it starts to bind to these H1 receptors. I like to think of this as almost being like a ball and mitt situation, in the fact that the histamine is, let's say, the baseball, and the mitt that catches that baseball is the H1 receptor. So it comes on down, it binds to the receptor, and what this allows for is just one thing, and it's that one thing that's really, really important when we're talking about the immune response, okay? And that one thing is vasodilation. So I'm just going to write out here, when this binds, what we get is vasodilation, okay? So the size of these vessels actually get much larger, right? They get much larger, much larger, much larger. Okay, so if I were to draw that out now microscopically, it looks a little different. So I'm going to do that for you. So let me get rid of some of this, right? And draw this back out microscopically, right? Because when you think about it, a blood vessel is like every other single type of tissue in the fact that it's made up of cells, right? It's made up of cells. So when you're looking at blood vessels, you're going to find that it's made up of these specific cells, what we call simple squamous endothelium, right? And so it's very flat, it's very small, it's only one layer thick, right? Which means that things can pass out. And what we can note about this straight away is that there are little gaps between the cells, okay? But upon this histamine binding to some of these receptors on the vascular endothelium, remember, we start to get vasodilation. So instead of it looking like this, now it's going to start to look something like this. So the cells get further apart and the diameter also increases, right? So this is now representative of vasodilation. Fantastic. So let's just draw this out, and remember that this is going to occur on both sides, but I'm just doing it on one side for the sake of simplicity, right? Now, we have to keep in mind that running through this blood vessel, which we've just stated to vasodilate, we also have to remember that we've got blood, right? We've got blood running through that vessel, sure. And what's inside blood? Well, I mean, very simply, we've got red blood cells, we've got white blood cells, and we've got plasma, right? Now, normally the reason for this vasodilation in normal inflammatory responses is so that the big white blood cells sitting inside the blood, they can get out. Normally that's a process named diapedesis or something called extravasation, but that's not going to be a topic for today, right? Instead, what I want you to focus on is the plasma, right? If I tell you that plasma is water, right, which theoretically it is, right? If it is water, would you agree that if I start putting holes through this vessel by, increasing the diameter, would the water leak out? Of course. It's kind of like getting a garden hose, right? I've got a garden hose, I get a little pin and I start poking all of these little holes in it, and then I turn on the tap. What's going to occur? Well, all of that water is going to start leaking out. It's exactly the same principle here. So let's start drawing out some plasma. So this is my plasma here, right? Let's say it looks something like this, right? looks something like this. It's now starting to leak out through the pores inside the endothelium, and now it starts to accumulate in the space outside of the vessel. And this is really important because this space outside the vessel is kind of a space between, nothing. It's not, there's nothing really there. It's what we call the interstitial space, right? And it's what we refer to as third spacing, in the fact that it's not inside the intravascular space and it's not inside the intracellular space, but rather it's just bathing in between. Okay, now normally it doesn't do too much and it's not really a problem. But in the case of anaphylaxis, where we get widespread vasodilation, we're also going to find all of this plasma starts pushing out of the vascular endothelium into the interstitial space. And when it starts to do that, that means that we've depleted the intravascular volume because we've gotten rid of that plasma content, right? And you might be thinking, well, why is that important? Why do I care, Jordan? Well, because remember that blood pressure is governed, okay? It's governed by intravascular volume, right? And if you're confused with that, you might be thinking, okay, well, why is intravascular volume indicative of blood pressure and vice versa? Well, if I were to draw out this, all right, if I were to draw out this is what we need to know. Firstly, intravascular volume, right, contributes to what we call the end diastolic volume. So this is simply the amount of stuff going back to the heart, or how much I should say is filling the heart, which is indicative of however much is pushed out, so the stroke volume. And then if we times that by the heart rate, we also get the cardiac output, and the cardiac output influences blood pressure, right? So what we've just learned here is that if we increase, or let's say if we decrease the amount of intravascular volume, we're decreasing the amount of fluid that is filling the heart chambers itself, what we call the end diastolic volume, therefore decreasing the amount of stuff that is ejected out. And if we times it by the heart rate, we decrease the amount of cardiac output, and then of course we decrease the blood pressure, right? So if you link those two together, by decreasing intravascular volume, we decrease blood pressure. Not good, okay? So how is it that we can identify this on a patient, and how is it that we can treat this with a patient? So firstly, what we need to note is that if we've got widespread vasodilation, right? So this is my vessel, and we have undergone vasodilation in the fact that these vessels have increased their diameter, they've gotten larger. Remember that more plasma leaves. Sure, that's fine. But remember, if this were my skin, right? If this was let's say this is my skin here, right? If I were to increase that size of the vessel, right, what you're going to note is that the redness associated with that blood, right, comes closer to the surface of the skin as it starts vasodilating, right? Which means if we have this widespread, you're going to note redness of the patient, okay? And that's incredibly important. Now, the second thing that you need to understand is, well, remember, vasodilation also means more plasma leaving into the interstitial space. So what you're going to find is this widespread swelling effect as fluid leaves into the third space. So another very important clinical feature of anaphylaxis, right? So swelling. So let me write those two down for you. So we've got one, we've got redness, and two, we've got swelling. Okay, so these are going to be some of the clinical features of it. And now if you think about, well, how is it that we can treat this? I mean, it's quite straightforward. Think about it. If we're losing fluid to the third space, would it make sense, or would it be justified to introduce fluid into the intravascular space? Of course. So if I were to get rid of this now, right, so we've got treatment. So remember, this condition is characterized by decreased blood pressure secondary to loss of intravascular volume. Okay, so how can we treat it? Well, firstly, what we can do is, I'm just going to change color here. What we can do, first thing, is we can introduce IV fluids, right? So IV fluids is directly going to increase blood pressure, and I'll go through how. So increasing IV fluids, let's go increase IV fluids equals increase intravascular volume, right? Which therefore, and I'm just going to draw another little arrow here, which increases preload, which therefore increases, remember, end diastolic volume, which increases stroke volume, which increases cardiac output, which increases blood pressure, right? So that's one of my big ones, right? So that's how we can reverse the decrease in blood pressure by giving IV fluids. That makes a lot of sense, right? Now, the second thing that we can do is deliver what we call epinephrine via a EpiPen. So I'm just going to get rid of this now. All right, so what I've got here, my second point is epinephrine. Now, what does epinephrine do? Well, it does a few things, and it's quite important. So let's write them out. Now, the first thing it does is it comes along, epinephrine, and it starts to stimulate the sympathetic nervous system, right? The fight or flight response. And think about every time that you're fighting or flighting, right? Let's say you go on a jog. Let's say someone is chasing you. What you're going to find is that your heart rate increases, the contractility of your heart increases, your respiration, or I should say your respiratory rate increases, your blood pressure increases, all of this good stuff to really allow more blood to the tissues that need it, i.e. the heart, the brain, the lungs, and the large muscles that are going to be utilized when we are running, fighting, or flighting. Okay, so we know that epinephrine is going to have an effect on those things. So specifically, what? Well, let's draw them out. So the first thing it's going to do is it's going to stimulate the beta-1 receptors, right? It's going to stimulate the beta-1 receptors on the heart, right? On the heart. And what this is going to do is it's going to increase heart rate, and it may also contribute to increasing contractility. Right now, the second thing it's going to do is it's going to come across and it's going to stimulate the beta-2 receptors. And these beta-2 receptors are embedded in, or I should say on the lungs, specifically on the airways of the lungs, so the bronchi and the bronchioles respectively. All right, and what it's going to do is it's going to allow for bronchodilation. Right, so we're going to widen the airway, and that makes a lot of sense because we want more air in to therefore improve gas exchange to allow more oxygen, again, to the tissues that need it. Okay, so beta-1 receptors, think beta-1, 1 heart, beta-2 receptors, think 2 lungs. All right, and then the last thing that we're going to find is that it also binds to A1 and A2 receptors, right, on the vascular smooth muscle, and it's going to allow for, so I'm just going to draw out my vessels here, so we're talking the arterioles specifically, right, and it's going to allow for vasoconstriction, right, it's going to allow for vasoconstriction. So these three things, by increasing heart rate, right, and by, actually, let's just do two things, by increasing heart rate and by increasing vasoconstriction, right, we're increasing TPR, right, and therefore we are increasing blood pressure. So these two things, heart rate, vasoconstriction, both contribute to blood pressure. And then lastly, remember the beta-2 receptors induce bronchodilation. And that's important because a lot of the time what we find with anaphylactic patients is that a lot of this histamine comes along and it causes bronchospasms in the airways, and it tightens the airways up, which means that air can't get through, right? So by giving epinephrine or something like an EpiPen itself, right, we're inducing bronchodilation inside the airways, allowing for oxygen, air, and therefore oxygen to come on in and perfuse the tissues via gas exchange. Okay, so very, very, very important. So keep that in mind when treating anaphylactic patients.